Hi, everybody. Dr. Ryan here, board certified specialist physician. Thanks so much for joining me. In this, our fourth didactic approach to internal medicine. Today, we are discussing. If you haven't yet subscribed to my channel, strongly encourage you to hit the subscribe button, like, and share. Thank you so much. So, from a conceptual perspective, guys, a useful first point to stratify a cough is to look at how long have you had the cough for? Is it acute, subacute, or chronic? And we use time periods of being less than 3 weeks as qualifying for being acute, anywhere between 3 to 8 weeks for subacute, and obviously or more than 2 months is chronic. So if it's an acute cough, we probably want to do a trial of therapy for infection. So consider if there's fever, other constitutional symptoms, start antibiotic. If there's asthma, you want to consider a beta-2 agonist, especially as well if there's other allergens or irritants the patient has been exposed to, and then reassess the cough. Most of the time, that would sort the cough out. But if it doesn't, if it's subacute or chronic, then continue with thorough history and examination, and probably you want to consider a chest X-ray. So if the chest X-ray is abnormal, there's many things which could go wrong. There could be consolidation, effusion, fibrosis, cavitation, suppuration, atelectasis, and often we find the diagnosis could be TB. Maybe it's cancer, maybe it's bronchiectasis. What about interstitial lung disease? Could be COPD or pneumonia, right? But if the chest X-ray is normal, are there any other red flags? That's the next question, right? If there are red flags like significant weight loss, etc., consider a CT thorax with or without a bronchoscopy. If there's no other red flags, then probably split the causes between respiratory and non-respiratory. So non-respiratory is one of the most common causes of cough, ACE inhibition. ACE inhibitors cause cough because they are responsible for pushing more precursor into the bradykinin pathway. And bradykinin, as you know, more prostaglandins to the bradykinin pathway, and that causes irritation of the cough receptors. Right, gastroesophageal reflux disease can also cause cough. It's actually associated with asthma as well as a postnasal drip. Okay, you want to consider antihistamines or maybe decongestant, intranasal decongestant, a beta-2 agonist. Okay, other causes of respiratory could be asthma, post-infectious, or COPD as well. Okay, looking at asthma, guys, the pathogenesis, three S's: spasm, secretion, and swelling. Spasm, secretion, and swelling. So, asthma is defined as airway hyperresponsiveness causing variable and reversible airway obstruction, okay, airflow obstruction. Various triggers, for instance, upper respiratory tract infections, often viral, allergens like pollen, animal dander, dust, and mold, air pollution. Usually, air pollution is associated with COPD. Drugs, especially aspirin. So there's a triad called Semtis triad. It's non-steroidals with asthma and nasal polyposis, right? Beta blockers can also do it. You don't want to beta block a patient who has asthma. Cold air and exercise as well. And it's thought to be due to a combination of genetic and environmental factors. There's a connection with atopy as well. So patients who have hay fever and eczema also go on to develop asthma in many instances. And what happens when you expose yourself to a trigger? It sensitizes your T helper cells, which stimulate the B cells to produce immunoglobulin E, which then binds to the mast cell surface, activates helper T cells and IgE. Sensitized mast cells now line the airways. Upon subsequent exposure, it results in spasm, secretion, and swelling. The net result, guys, increased vascular permeability, goblet cell hyperplasia with increased mucus production, bronchial smooth muscle contraction, you get airway obstruction, right? Eosinophilia also migrate to the airways, causing bronchiolar constriction, so the eyes causing conjunctivitis and nose causing rhinitis. The net result is asthma. So swelling, secretion, spasm. You guys know that. Then, of course, while we're speaking about COPD, we know that the key word with COPD is poor reversibility. So if you give a patient or do a PFT on a patient, it shows you an obstructive pattern, the classical scooping of the expiratory limb. But if you give the patient two parts of beta-2 agonist, it is poorly reversible. And reversibility is defined by a 12% improvement in FEV1 and 200 moles post bronchodilator. And that doesn't happen with COPD. Alrighty. And of course, COPD pathologically is divided into chronic bronchitis and emphysema, blue bloater, and the pink puffer, right? So chronic bronchitis is diagnosed clinically as daily productive cough for at least 3 months or more in 2 consecutive years. Emphysema is more pathological diagnosis, refers to permanent enlargement and destruction of the air spaces distal to the terminal bronchiole, okay? Prototypical chronic bronchitis patient is overweight and cyanotic with elevated hemoglobin, peripheral edema, hence the term blue bloater, together with rhonchi and wheezing. But emphysema, we find the patient's older and thinner, is severely tachypnic and dyspneic, right? He often has a quiet chest. And what you find on X-ray is typical hyperinflation, so more than 10 posterior ribs on the PA film with flattened hemodiaphragms, a very tubular heart. COPD, like we said, typical X-ray findings, guys, massive hyperinflation, more than 10 posterior ribs, highly enlargement on account of pulmonary hypertension, right? Increased lucency of the lung fields, very thin, narrow heart. On the lateral, you may find increased size of the retrosternal airspace, which speaks to hyperinflation, increase in the AP diameter, which is a so-called barrel-shaped chest, and flattening of the hemodiaphragms. Okay, let's talking a little bit about gastric and peptic ulcer disease because we said that GERD, gastroesophageal reflux disease, can also cause cough. But if dealing with gastritis and peptic ulcers, guys, most of the time it's either caused by Helicobacter pylori infection, chronic use of nonsteroidals, or even things like alcohol, stress, shock, and steroids. You diagnose it usually, you can do a urease breath test or you can do an upper scope. We manage it with calcium antacids, H2 blockers, but those are the older modalities. Now we use proton pump inhibitors. Okay, and if you can see an ulcer, then you need to use triple therapy, usually a PPI together with 3 antibiotics. For instance, one example of regimen is omeprazole 20 PD together with aspirin, so rather azithromycin 1 gram PD and clarithromycin 500 milligram PD. Of course, ulcers can complicate with GI bleeds, perforations, stomach and duodenum and gastric outlet obstruction. If you have ulcers in many locations, many weird locations, you got to think about Zollinger-Ellison syndrome with the so-called gastronoma triangle. Okay, my friends, humility, humility, and humility, right? James 4 6 and 1 Peter 5 5 are two scriptures in two different books by two different authors who say the same thing that God opposes the proud but gives grace to the humble. So Chronicles 7:14, I'm sure many of us probably know this one by heart. If my people who are called by my name will humble themselves, turn from the wicked ways, pray and seek my face, then I will hear from heaven, forgive their sins, and heal their land. But I just want to draw attention to humble themselves. We got to humble ourselves. That's quintessential. God bless you, and I'll see you soon with another video. Here are my references, guys.